several people with me here today. Sheena McCody, who's a gastroenterologist from the Whittington. Ed Seawood, who's a gastroenterologist from UCH. And Zarina Cuddis, who's I work with very closely in Barnet, who's the cancer lead, Macmillan cancer lead for Barnet. And all of us over the last, Ed and I first started, I think, talking about FIT in about 2017, but we've come a long way since then. And we're here today to talk to you about the changes, the recent changes in the pathway. So just as a reminder, this is a webinar that we're doing jointly between the, NCLCCG and the Cancer Alliance. Cancer Alliance, as many of you will know, is one of 21 cancer alliances in the UK. And we're covering the geography of NCL. And all of you are our partners, patients, GP practices, hospitals, healthcare commissioners, local councils, charities, the third sector. So we're here just to make things as good as we can for cancer, to reduce variation and to bring new innovation into practice, which of course is what FIT is for the kind of colorectal dialogue. We've had some changes in our pathway, partly triggered by COVID, and then on from that, from the work that we've done around the research into using FIT in 2-week wait patients, both in the community and those referred in hospital. So I'd like to introduce Zarina first, and we're going to hear from from all of our speakers about how we've moved through the pathway and how what changes we're making and what we need to ask you to do from primary care. In terms of housekeeping, as you know, it's helpful if everybody stays on mute, apart from the person that's speaking. And we'll take a Q&A at the end of the presentations, but I'll also take questions earlier on if you like. If you just put your raise your hand, and I'll invite you into the dialogue when appropriate. We've got a feedback survey at the end, and I think it'll just be a really good chance to have a dialogue about this really important subject. So if I can introduce Zarina first, and I'll let you just say a little bit about who you are, Zarina. I know you're a local GP and what you've been doing. Thanks very much.
Lovely. Thank you very much, Claire. So I'm Zarina Cuddis. I'm a GP at Cornwall House Surgery in Barnet. And as Claire mentioned, I'm also the Macmillan Cancer GP for Barnet. And I'm very pleased today to be able to present to you the new pathway that we have. So I'm just going to bring up my slides, and please let me know if you can see them. So bear with me. Sorry.
That's it, Zarina, we've got them. Thank you.
Yes, lovely. Thank you. Okay, so as I mentioned, I'm going to be talking about the FIT less than 10 NG12 follow-up pathway. And today I'm going to be going through some of the background that's led to this pathway, and then talking mainly about the process of the referral for the pathway. So as most of you know, in terms of colorectal cancer, it's the third commonest cancer in the UK, and approximately 40,000 new cases are diagnosed in the UK each year. And that accounts for about 12% of all new cancer cases a year. It's also the second leading cause of cancer deaths. And if it's caught early, more than 90% of patients have a chance of cure by surgery. In terms of diagnosing it currently, we use colonoscopy, which is an accurate diagnostic measure. It is invasive and costly, and it can miss up to 10% of cancers, although it still remains a very good tool. One of the difficulties we have with colonoscopy is that unfortunately our capacity is not unlimited, and this has been a problem particularly during COVID. If we went on just symptoms alone for colorectal cancer, only 4% of patients with symptoms who undergo a colonoscopy would actually have colorectal cancer. So it's a major consideration for us when we're thinking about resources. We also have the Fecal Immunochemical test known as FIT, which replaced the Gwysick FOB test. And this detects hidden blood in the stool as an indicator of colorectal cancer. And unlike FOB, it's much more specific in detecting human hemoglobin. It's actually highly accurate, and it's a very good, it's highly effective at ruling out colorectal cancer. So it's got a 99% negative predictive value. And also, unlike colonoscopy, it's cheap and non-invasive. So in England, we have a diagnostic cutoff of 10 micrograms per gram. So the way in which FIT measurement is it measures the micrograms of hemoglobin per gram of feces. So in England, it's set at 10. So you would be considered to have a positive result if your FIT test was more than 10. We also have other sort of novel technologies, such as colon capsule, which Dr. Sheena Mankodi will be talking about later on.
Zarina, sorry to interrupt. Is it possible to enlarge the slides? We're not seeing them in full screen, so they're a little difficult to read.
I'm so sorry, it's showing it full screen for me.
I know sometimes Teams is a bit weird with the slides.
Let's just see if there's anything else.
Try it on slides.
Yeah, that's better. Perhaps if you just enlarge on the bottom, zoom it up.
Sorry, just tell me how.
Yeah,
That's fine.
Can you see the whole slide?
Yeah. Yes, we can. We can.
Yeah. Any bigger at all? Do you want it any bigger?
I think that's okay for everyone. I hope so.
Okay. Just to remind people, if you're as you're watching this presentation, if you wanted to click on the slide, and then if you happen to have a machine where you a trackpad where you can separate your fingers across the trackpad, then you will enlarge that image as you're looking at it yourself for any of us who are watching as guests. Thanks very much, Serena. Thank you.
Okay, so as Claire mentioned, FIT's been around for some time now. I'm going to talk about how it's been phased in NCL, really just as a diagnostic tool. So we had phase 1, which started April 2019, and this was following NICE DG30 guidelines. So DG30 is basically patients who are sort of low risk of having colorectal cancer. Essentially, it's patients who sort of without rectal bleeding, but who have unexplained symptoms, but don't meet the high risk criteria of suspected cancer. So the guidelines suggested that FIT should be done for these patients and used as a decision tool, really, whether to refer them onto a 2-week wait, lower GI pathway. We then had phase 2 in June last year. So this really came about sort of very early on in the pandemic. It was obvious that endoscopy services were not going to be able to meet the current rates that they had. And so the use of FIT became sort of accelerated at that time. And this was backed by NHS England, and it suggested that FIT should be used in patients, so high-risk patients. These are patients with NG12 symptoms, and it should be used before referral. And then if the FIT was more than 10, they should be referred onto the 2-week wait, lower GI pathway. There are some categories of patients that one wouldn't do FIT, and I will talk about those later. But essentially, this pathway was introduced with FIT to try and identify the high-risk patients so that we could see which patients were most at need of colonoscopy and direct the services, to them. We then have phase 3. So this is the pathway that we're talking about today. This is the FIT less than 10 NG12 follow-up pathway. It's not a 2-week wait pathway, so that's really important to know. And so whereas when we do the NG12 FIT test, for those I've already mentioned, for those more than 10, they're referred onto the 2-week wait pathway. For those less than 10, what would have happened until now is that the GP would have safety netted those in primary care, and just told patients to come back if they had either new or progressive symptoms. But now what will be happening is that these patients will be referred to on this pathway, so they'll be referred into secondary care, and secondary care will then follow them up and determine whether they need any further investigations or not. This is actually a one-year service evaluation study, and the idea is really to try and get more robust or sort of detailed information about the use of FIT, and hopefully this will then help us refine the lower GI pathway using that information, which is phase 4. Has the slide changed? Sorry, because it hasn't on one of mine.
We've got
yes, it has. Yeah.
Okay.
Yeah,
all right. So as I mentioned, there are certain circumstances where it isn't appropriate to use FIT. So one of these is iron deficiency anemia. And the reason for this is that FIT has been found to be much less reliable in these patients, and there's a greater risk of FIT missing cancer. So these patients should be referred directly on the 2-week wait pathway, as they always have been. We then have the high-risk patients. So these are patients who are particularly high risk because they have either a rectal mass or been found to have sort of anal ulceration. And these patients should also be referred straight on the 2-week wait lower GI pathway, and there is no need to do a FIT. So here I've just listed, just really to remind everybody, what the DG30 and NG12 criteria are. So the NG12 is in the red box, and that shows the high-risk patients, and the green box is the DG30, which shows the criteria that suggests the patient is of lower risk. So I'll just sort of run through it, but the NG12, so this is patients 40 years and over with unexplained abdominal pain and weight loss, patients 50 years and over with unexplained rectal bleeding, patients 60 and over with iron deficiency anemia or change in bowel habit, under 50 with rectal bleeding and any one of the following, so abdominal pain, change in bowel habit, weight loss or iron deficiency anemia. And then for the DG30 criteria, so it's those over the age of 50 with unexplained abdominal pain or weight loss, those under 60 with changes in bowel habit, those under 60 with iron deficiency anemia, and those 60 and over with anemia but without iron deficiency. Okay, so if one wants to order a FIT test, one would do so on TQuest or SunQuest, depending on which system that you have. You would use the search box to either put in FIT or Fecal, which would bring it up. My main reason really for showing the screenshots, I think we're all probably quite familiar with our ordering, but it's just to show that there's a little box just next to add. I hope you can sort of see it, but it's called info. And if one is to click on that, it automatically brings up the FIT Instructions Leaflet. So that's a leaflet that you would give to patients at the time of ordering the test so that they knew how to do it properly. Just to say that that instruction leaflet has also been translated into many different languages and is available on the NCL. There's an NCL FIT page sort of dedicated to all the resources of FIT. So they're all on there. Okay, so this slide really is just to go through what you would do in terms of outcome with your FIT test. So the first thing that one needs to think about is which category the patient's in. So are they DG30 or sort of NG12, as that's what would affect what you would then do. So if the patient had DG30 symptoms, if their FIT was less than 10, then they would be safety netted in primary care. If their FIT was more than 10, then the patient should be referred on the 2-week wait lower GI pathway. If the patient had NG12 symptoms, if they fell into the category of having iron deficiency anemia, a rectal mass or anal ulceration, then they also would be referred straight on the 2-week wait pathway without needing to have done FIT. If they have any other IG12 symptoms, then if their FIT was less than 10, you would refer the patient on the 2-week wait pathway. But if their FIT was less than 10, you would then use this new pathway called the FIT less than 10 NG12 follow-up clinic. Just to mention, there is another group of patients where you might consider doing FIT. So these are patients generally who've got an unexplained weight loss, no definite GI symptoms, but a high clinical suspicion of cancer. And the general recommendation is that in those patients, you should try and consider other cancer sites and other diagnostics. So you might want to do a chest X-ray, you might want to do other sort of direct access scans. But if these do not lead to a diagnosis, then one should consider doing a FIT test. And again, if the FIT was then more than 10, you would refer on the 2-week wait lower GI pathway. But if it was less than 10, then you would consider referring them onto the RDC pathway, which is the 2-week wait cancer pathway for sort of more non-specific symptoms. And that's in the 2-week wait folder on EMIS. Okay, so in terms of patients being referred on this new pathway, the reason that we have it, so basically if we have a FIT less than 10, as I mentioned, it's got a very good negative predictive value. So we know that more than 99.5% of patients will not have colorectal cancer. So you might wonder why we're following them up. And the reason is because although they're low risk, they're not no risk. And so really the hospital are following up to ensure that these patients don't go on to develop any changes in their symptoms or in their test results, and just to make sure that there is no significant sort of underlying pathology. So the referral form for this can be found in the 2-week wait cancer folder in EMIS, BAR Global, or the equivalent in your borough. It isn't a 2-week wait pathway though, and we've put it there just to have all the cancer documents together so that it's easy for people to find. And what we've tried to do is we've tried to make the format of the form different to the 2-week wait other forms so that people don't get confused. In terms of referral, the referral would be done via ERS. And the current services, the current hospitals that provide the service are the Royal Free Barnet and Chase Farm site, UCLH, North Middlesex Hospital, Whittington, and the Royal Free Hospital in Hampstead is due to start soon, but I don't have a date yet. I just want to very briefly touch on the ERS sort of process. I have to say it is a little bit confusing, and we will be putting instructions on how to do this on the NCL FIT page. But just to say, this is how to find the UCLH site. One would go in for priority, one would select routine, specialty GI and liver, clinic type colorectal surgery. And unlike some of the other, like the 2-week wait ERS referrals, where we normally would just put search all, to find these ones, you have to put search primary care. And then you will, in this particular case, it comes up with a FIT less than 10 NG12 follow-up colorectal surgery for UCL. At the moment, the other ones aren't showing on there, and I'm still waiting clarification as to what is happening. But as soon as we have those details, that will all go on the NCL FIT page, and I would hope that it won't be long, that it will be sorted out. But if you have any queries, please feel free to email me, and I will do my best to help. Just to say, the reason it's been set up for search primary care rather than search all is because they want any practices in NCL to be able to see this service. So it's just been done for those reasons. So here is the referral form. As I mentioned, we've tried to keep it its format a little bit different to the 2-week wait forms. And so just, I mean, most of the form is probably self-explanatory, but just to say a few things. So you must have the a fit result for the referral, because obviously without that it's very difficult for the hospital to know how to manage the patient. It's also important there's some tick boxes in terms of suitability for telephone clinic, for example, whether the patient has dementia or a learning disability or anything that could make that difficult. Most of there's one telephone clinic appointment at 3 months, and that's where the patient has their repeat test, full blood count and fit tests discussed, and so that's a reason for the questions. If a patient wasn't felt to be suitable for telephone clinic, then they would be brought in for a face-to-face appointment. The other thing that's very important on this form that one would need to add is whether the patient has had any recent GI investigations in the last 12 months. And it would be important to say at which hospital, the specialist and the date. And then on the right-hand side, it shows the NG12 categories. And you can see on the bottom half of the form, it's got a tick box for which of those categories apply, which you should then tick. And then there's some boxes that just ask you to confirm that you've let the patient know that they'll be contacted by the hospital by letter. So I will go through the process shortly, but just to say that they're aware that they will get a hospital letter first, and also that you've checked that you have the correct telephone number on the notes, because that is how the hospital will be contacting them. Also, investigations. So these are investigations you would have done as part of your initial assessment, so the full blood count, iron studies, CRP and renal function. I have to say that these don't always come up automatically on these sections, but we do have a sort of backup under investigations here where it pulls in all the results that have been done over at least the last 6 months. So even if you don't see the results in those boxes, they should still be appearing on the form. And the reason there's been difficulties with that, I think, has been due to SNOMED, but IT have worked quite hard to try and find a way to make sure all the data is still on that form, but perhaps just sort of make sure that you can see those under the investigations. On the right-hand side, I've just listed, that's the website, the page that's dedicated to fit test. And on that page, one of the resources that's there is actually a GP letter. And this is a letter that you give to the patient at the time of referring them to this pathway. And it's really just to inform them of the process. This letter will be put on EMIS under leaflets as well. That hasn't been done yet, but it will be done. Okay, so just talking a little bit about the actual process of the referral. So as I mentioned, it's a 1-year service evaluation project. And so what happens is the hospitals will receive the referral. They will then send a letter to the patient confirming that they've received the referral. And the letter will tell patients what to expect. So that is that patients will be sent a full blood count and asked to do a repeat fit test at 8 to 10 weeks from referral. And then 2 weeks following that, they will have ideally a virtual telephone appointment if they can manage that, otherwise face-to-face. But in most cases, it will be a telephone assessment. And that will be with a senior decision maker, a specialist, who will look at the repeat fit test, the full blood count, and will discuss with the patients about their symptoms, and then make a plan as to what, the follow-up. So just to mention, in terms of the tests, the fit test and the full blood count, that will be purely organised by the hospital. So they will send the instruction sheet, they will send the testing pot and all the information, and they will also advise patients of booking their full blood count at the hospital. and give them all the details on how to do that.
So I'm just doing a, yeah, okay.
Okay.
Sorry.
It's Zarina, it's Claire. I think someone was just talking over you, don't worry.
It's okay. Okay. Thanks. And so following that, that telephone appointment with the specialist after a patient's had the test, they will then decide. So most patients will be reassured that they have no worrying features and will be discharged from the service. A small amount they might decide to investigate. They may be upgraded straight to a 2-week wait for investigations, or they may just actually be kept on a sort of sent more on a routine pathway for more investigations as well. And whatever decision is made, the GP will receive a letter at that time, just telling them what actually the end outcome has been. And the hospitals will be tagging these patients. They'll be on a tracking list, everyone that's referred to them, and they will follow them up for a sort of 12-month period. So what will happen, the patient may be discharged at 3 months. They won't be contacted again by the hospital, but they will just almost be tagged so that, you know, the hospitals will search at 6 months and at a year, just to see what's happened with the patient, whether they ended up having any more investigations with regard to colorectal cancer, and whether they ended up with any positive diagnoses. And it's this information that will be used to sort of determine sort of more detailed use of the FIT test.
Zarina, can we go?
Yes.
We've got quite a lot of questions in the chat, so I thought perhaps we would just go to answer some of those so that we just kind of keep the
Sure.
Sure.
I'm almost there, to be honest, but I'm happy to do that. That's fine.
Have you got any other slides that you want to show now?
No, I mean, I was just so you know what's ahead, but just really just talking about the benefits of this evaluation pathway, why we're doing it, and also just talking about
the screening reminder. Yeah, the differences in FIT. Thank you.
Resources.
That's really helpful. I thank you very much, Zarina. I think because of time, let's go to some questions. We might come back to share those in a minute. So if you stop sharing for a second, and I'm just going to bring in Ed Seaward, who's with us. Ed is the lead gastroenterologist at UCH, and he's led the research work that we've done on FIT across the geography. Ed, I don't know if you can put yourself on screen and we'll just answer some of the questions that we've got in the chat. Thanks very much. So I wondered whether you wanted to first address the question around age appropriateness for FIT, and what's the bottom cutoff. And obviously there's a difference between whether it works chemically in relation to what we see in clinical pictures in clinical practice. Thanks, Ed.
Yeah. Thanks. So and thanks very much for involving me today. The thing to stress is that FIT there's nothing special about FIT. It's a clinical aid. It obviously doesn't stop us chatting to our patients. FIT is there if the differential in your head is, could this be colorectal cancer? One issue we've noticed when patients are being referred up now, particularly if they're young, say you've got a patient in their 20s, let's say you think it could be IBS, but there's a diarrhea predominance, and sometimes what people are doing is they're doing a calprotectin and a FIT. Now, a calprotectin in somebody that age is really sensible, because obviously the main differential is inflammatory bowel disease. Using a FIT is a really bad idea, because the FIT could well be positive because of let's say they do have inflammatory bowel disease, or maybe they have hemorrhoids, but then the FIT will almost demand a 2-week wait referral, and then that patient ends up having a colonoscopy off the bat, when clearly the differential is not cancer. So it's really just to remind everyone, and there was a question on the chat I saw, what's the minimum age? You can do a FIT on anyone you want. but you must have to hold the differential of cancer in your head. Because if you're just doing a FIT blindly, then it's really unhelpful. But I mean, essentially anyone over 40, 45, certainly anyone over 50 with new bowel symptoms, a FIT is obviously a really good idea, because that's when your colorectal cancer is higher up on your differential. But otherwise, try and avoid doing it on younger patients, unless there's a really good reason why you might suspect cancer, really strong family history, previous polyps, marked weight loss or something, and you don't think it's IBD.
Thanks very much. Thank you. That's great. We've got some questions around. Can I just bring you to the one in the chat, Ed, from Miles, saying, Miles, perhaps you want to speak your question. Do you want to speak it? That might be easier. Say it now to all of us. You were talking about rectal bleeding and IDA. Yeah.
Yeah, there was a couple of questions I brought up, but one of them just in terms of the pathway, the NG12 symptoms, and going straight to 2-week wait. If you're over 60 and have IDA, you're straight to 2-week wait. If you're under 40 with rectal bleeding and IDA, you're straight to 2-week wait. But if you're between sort of 50 and 60, you effectively just go for a QFIT if you have rectal bleeding and IDA, because it's not made clear.
Yeah, I mean, I would encourage anyone not to get too hung up on the. We're saddled with NG12 and
DG30.
DG30, thank you. And so there's not very much we can do about those.
I think what Ed means is those are NHS England UK constructs, which the rest of the world doesn't use. So we're trying to obviously reflect what's in our national arrangements, but in terms of when you start putting that in the context of international research, it doesn't quite fit. That's what you mean, isn't it, Ed?
Thank you, Claire. That's exactly what I meant. So but if you've got the patient in front of you and you've got a 50-year-old with new onset iron deficiency anemia, that would be a 2-week referral in my book. So I wouldn't. I'm less concerned about those. It's the guys we're struggling with are the young people referred up with positive fits. They're the ones I have the bigger issue with. So if you're coming down to the nuance of it, nobody's going to pick you up on that, because I think it's where you use good old-fashioned common sense. I hope that makes sense.
Does that help, Miles?
Yeah, no, I think it as I put in my question, I think it's common sense that you would refer those onwards, but it's not made very clear. And the 2-week form hasn't yet been updated in Enfield, so it's still the old one, which says everyone needs a fit first.
Okay, well, we've been advised. So I think that Zarina's been having a look at those on all the different platforms. I don't know quite why that's there. Of course, it depends how you're accessing the. Are you looking at the website or are you looking through EMIS?
EMIS Global Library.
And is that sitting on the website or is that sitting on EMIS, on your clinical EMIS system?
That's my clinical EMIS system. I checked it.
Okay, yeah, okay, thanks. So that's we'll have a look at that again. It should all have been completed before we started the talk, as Jonathan rightly put in the chat, and you're right about that, Jonathan. So I'm sorry what that's happened in Enfield, and we'll check it. I'll check it again. I don't know, as you know, all of you, the NCL's wide website has decided to discontinue all the separate borough websites. And that can be a problem at the moment, because theoretically it's still possible to action them, although they're not being updated, and you will all have had individual emails advising about that. But I agree, it's sometimes difficult in clinical practice. So we'll try and get rid or block access to areas of the web that are out of date. But as you know, it's extremely difficult. If the Metropolitan Police tell me they can't remove sites they want to take down, then I'm going to be we will be a little bit restricted by what we can take down. Let's go. I'm conscious of time. Ed, you can see the chat, can't you, in front of you? I think, is that right? Are there any particular questions that you wanted to bring out that we
I mean, only just to answer Miles's second question, which was about what happens if they DNA. So we, certainly at UCLH, I can't speak for the other NCL hospitals, they're meant to have another go before you then cross them off the list completely, and we would do the same rules for the fit less than 10. So they do get 2 bites of the apple, just to reassure you.
Is that okay, Miles? Helpful. Okay, thank you. I'm just going to ask people, right, thanks, Miles, that's good, thumbs up. I think what we should do now, we're going to have a listen to, hear a little bit more about colon capsule, and then I think, Ed, we were due to also cover calprotectin. I wonder whether actually it will fit better if we do a bit of calprotectin now and then go to colon capsule for Sheena. Is that okay for you, Sheena, if we do that?
Yeah, it's absolutely fine.
Right, great. So I think let's do calprotectin, Ed, because it might fit together quite well with some questions we've got around fit. Thank you.
Now, for some reason, I can't take charge. Don't know why.
You could talk if you like, and then we could just.
Can you, in which case, I have sent my slides through. Could somebody put them up, please?
Thanks very much, Amanda.
Thanks. Sorry about that. The little button was there and then it's disappeared. So essentially, just to talk, so calprotectin, we're staying with all things poo
just for a short while. Thank you.
This afternoon, just for a short while. So everyone knows everything about fit now. So calprotectin is basically a chemical which is generated by mostly neutrophils in obviously response to inflammation. So next slide, please. Next slide. So there is nice guidance on use of calprotectin, and basically what it boils down to, it's there to help you differentiate IBS from IBD. It does go up in cancer, but not reliably so. So if you think there's cancer, use FIT, do not use calprotectin. Next slide, please. And this is a sort of sensitivity specificity. So as you can see, it is really sensitive test. It's really good for the presence of inflammation. Less specific for reasons we're going to talk about in a sec. Next slide, please. So the British Society of Gastroenterology have also given some opinions on calprotectin. Interestingly, just from a practice point of view, it's stable for 3 days, but doesn't deteriorate for a further 7 or 7 in total. So you can tell that to your patients. I always find that really helpful, that they don't have to sort of dash to the lab with a sample of stool shoved under their armpit. They can wait until the next day. It's completely fine. So in terms of other things that push up calprotectin, so obviously infections, diverticulitis, cancer we've already mentioned, and non-steroidals. Unsurprisingly, it's more useful in colonic than small bowel disease. So, and this is something we see on the IBD side, that it will be sky high in colitis, but if you have a bit of jejunal Crohn's disease, it might not push up your calprotectin. And the BSG also flag this intermediate range. Now, this intermediate range is a bane of any gastroenterologist's life, so I want to focus on that. So next slide, please. So this is a really nice paper, and it's very approachable if you've ever got 5 minutes. It's in Frontline Gastro, which is a sort of very practical journal, and it's done by a guy called James Turville in York, and he took a bunch of patients and looked at their calprotectins, and he's generated this algorithm, which is what we've proposed to use which has actually been passed in NCL. So what it boils down to is what your first fecal calprotectin is. So if your fecal calprotectin is less than 100, and I'm looking at the left-hand side of the pathway here, you've got a 98% certainty that patient has irritable bowel syndrome. And I find that really helpful from a clinical point of view. I can look my patients in the eye and say, look, you don't have inflammatory bowel disease if your calpro is less than 100. And then you just go ahead and treat them with IBS. And if they're symptomatic, then you can obviously repeat the calprotectin or consider alternative diagnoses, and that's all fine. If the calpro is greater than 100, they then ask you to repeat a second calprotectin. Now, this will include if your initial calprotectin comes back as 3,000, and you think, oh my God, there must be something really major going on here. But of course, because calprotectin goes up in the context of infection, if your patient's got Campylobacter or Shigella or whatever, you do a calprotectin on them, it's going to come back as 3,000. It's going to come back as really high. That doesn't mean they have IBD. And this is where the sort of history-taking bit is important, whether it's an acute history compared to a chronic history. But you have to repeat the calprotectin. That's really important. If the second calprotectin is really high, then that makes inflammatory bowel disease much more likely, and then you have to refer to gastro. And gastroenterology are obliged to offer urgent appointments for inflammatory bowel disease, and that's to try and take some pressure off the 2-week wait pathway, because I'm very aware that really out of desperation, sometimes these patients get referred on the 2-week wait pathway to get sorted out. So NCL hospitals are meant to offer an urgent gastro pathway for these people. If the second fit is less than 100, then we're back to a diagnosis of IBS. So next slide, please. So this is what it looks like in NCL. So this was a product of the outpatient transformation program, and this is a pathway done by GPs for GPs. So if we skip on to the next slide. So this is just taking you through it. So new presentation with lower GI symptoms, cancer not suspected. Obviously, that's really important. And you boil down to IBS versus IBD. It suggests some sensible blood tests, which I don't think are too controversial. And then it suggests a calpro. And again, it's the same pathway. So if it's less than 100, you're pretty sure it's going to be IBS, and you treat as such. If it's over 100, you have to repeat the calprotectin to try and decide whether it's going to be IBS or IBD. Next slide, please. And then again, this is just the bottom half of the pathway, which again exactly reproduces James Turville's data. So on the right-hand side, an elevated repeat calprotectin, you're going to either refer them up routinely or urgently, depending upon how high that calprotectin is, and that affects the likelihood of IBD. Whereas on the left-hand side, you're going to manage them as IBS unless things drag on and you get a bit uncertain. And then there's a whole bunch of very sensible things about how to manage IBS that I won't go into. Next slide, please. So really, just to summarise, calprotectin, very sensitive, reasonably specific for IBD. It's great when you're trying to work out if it's one or the other. Don't use if your differential is cancer, then you use a FIT. Conversely, don't use a FIT when they're young, use a calprotectin. And please don't refer the marginal calprotectins. I get quite a few referrals where the calpro's 60 or 70 or whatever. These are not elevated. Just follow the algorithm and you won't go far wrong. Next slide's the last slide, I think. Yeah, great. Thanks. Any questions about that?
Thanks very much. Have you got any questions about the using calprotectin, or any queries that people have around that? I think the really useful thing was probably the most useful thing, Ed, was that last phrase around if they're young, use calprotectin as your first line, and if they're older, use FIT.
Great.
Is that right? Got that right?
Yeah, absolutely. Yeah, it's all about what differential you're carrying in your head. And if your differential is IBD, it's calpro. If your differential is cancer, it's FITs, and that's really important. Not both. Never send a FIT and a calpro together. Okay,
that's a really important message. Thanks ever so much. Thank you. Let's move to Sheena. Sheena Mankodi is joining us today. Thanks so much for sparing the time, Sheena. So Sheena's also a gastroenterologist at the Whittington, and you've been in NCL, I think, for well over a decade working in the area. Thanks so very much for coming today. And I think you're going to talk to us about colon capsule and the work you've been doing around this. Thanks very much.
Hi, thank you for involving me. Can you see my slides?
Yes, absolutely. Yeah, thank you.
Let me just swap them around. There we go. Okay, so yeah, I'm Sheena Mancody, I'm one of the consultants at the Whittington Hospital. I'm just going to briefly talk about colon capsule endoscopy because you may find some of your patients having this instead of a colonoscopy or a CT that you're expecting when you refer them in. So on average, we get in NCL about 1,000 patients who are sent in for low GI 2-week wait pathways. And the majority of these patients do not have bowel cancer. We know that there's only a very small proportion who do, about 4%. With COVID and our 2 big waves of COVID, endoscopy activity was very much limited. And even now, when most units are back up and running to pretty good capacity, with the way we have to deal with infection control and social distancing, there is still a bit of a limit to how much we can do in optical colonoscopy, traditional colonoscopy. So NHS England started this pilot to look at capsule endoscopy as an alternative investigation to CT or colonoscopy, and it was launched in March 21, so just recently, and the plan is to involve around 11,000 patients at 40 different sites to look at how colon capsule endoscopy is as a diagnostic tool compared to the others. So this is what a colon capsule looks like. It's a little pill with 2 cameras, one on each end, takes photos as it travels through, and the patient wears a belt, which is a data recorder, and the capsule is excreted. You don't have to collect it. You just have to bring the equipment back the next day. Sorry, apologies for the noise. It's a very specific and sensitive test. It's been used in Scotland since 2018, and other units, even in NCL, Royal Free, have been using colon capsule endoscopy for a while. It's non-invasive, which is really good for patients. There's no, very little risk. There's obviously a risk of retention with any capsule, but compared to the risks of colonoscopy, it's much preferable. You don't have to have sedation, you don't have to stay in hospital, and actually the whole procedure could be done at home with a competent patient. The disadvantages of it is that it does require a little additional in the way of bowel prep compared to traditional colonoscopy. And of course, we as gastroenterologists have to be trained to read the images. So within NCL, we've got 3 sites that have joined this pilot. The Royal Free, as I said, already were using colon capsule previously, and they're going to join the pilot for the cancer pathway. UCLH has gone live already, and we're about to go live very soon here at the Whittington. We hope between us to get about 200 patients to participate in this pilot. And the eligibility criteria will be those with FIT 10 to 100, or very rarely a few who sneak in with a FIT less than 10 with concerning symptoms. But just so that we're clear, those decisions as to which test the patient gets will still very much be within the hospital. So when the GPs refer people in on the 2-week wait pathway, some of them get a colonoscopy and some of them get a CT colonoscopy. You'll now find that some of your patients may get a capsule colon endoscopy instead. There are some patients, obviously, that it can't be used for patients who have risk of having abdominal small bowel strictures, and if your patient's pregnant. If we do find a polyp on our colon capsule endoscopy, your patients will be referred for a colonoscopy and polypectomy. And just as other 2-week wait low GI investigations, if it's negative, most of those patients will be discharged back to primary care. Oh, I have a little YouTube video here, which is actually Dr. Seward's video. If I can I have to stop that one and then reshare this one. It's just a really nice video. Okay.
It's the science.
So that was the end. That was my last slide. So if there's any questions, I'd be happy to answer them. It's very quick.
Thank you, Sheena. I'm not sure if everyone had heard the audio while you were playing the YouTube. So in summary, was there anything extra to that which you've already said about it?
No, it was just the benefits of having a capsule instead of a colonoscopy. There's fewer risks. They don't have to have a camera put in. There's no radiation like CT would have, and just gives you a bit of size and the pictures.
Okay, that's great. Can I just ask, if we particularly thought a patient of ours would benefit from this, is there any way of flagging that patient to you, or are you at the moment in terms of study just picking up the people that you need to pick up?
Yes, I think at the moment, with it being early days, we're highly selecting our patients.
Okay.
If it can always be written on the 2-week wait referral that you think they would be suitable for a colon capsule. So they need to be motivated patients who will be able to take their bowel prep and also take the boosters and perhaps an extra suppository as well. They'll come through the 2-week wait pathway. Typically at the Whittington, it's through the surgeons, and then the surgeon's going to highlight the patients they think would be appropriate for capsule. So if there is someone that you particularly think would be, if you just write it in the free text section of the 2-week wait referral, then that will help everyone flag that patient. Yes.
But presumably these are patients who have that you perceive to have a lower chance of requiring biopsy?
Correct.
Yeah.
So, in the ideal world, these are patients who don't have any polyps or any pathology. Obviously, that's not necessarily what will always happen. But what we don't want to happen is every single patient who has a capsule then goes on to need a colonoscopy for a biopsy or a polypectomy. So it's about finding out that pathway and how it's going to work over the next year, and whether it's beneficial to use capsule endoscopy on the 2-week wait pathway, or actually is it beneficial not to use it on the pathway and to use it for other indications.
Okay, that's really helpful. Thank you. I wonder if anyone has got any particular questions they'd like to ask Sheena. How long have you actually been running at Whittington now, Sheena, in terms of this programme?
So we've been running a small bowel capsule service for over a year. So we're well versed on how to administer capsules, but the colon capsule service would be a new service to the Whittington Hospital. Right.
Okay, that's really helpful. Thank you. Thanks very much. Anything else you think you'd like to remind us of? Otherwise, I'll open it up to questions, but I haven't got anything extra in the chat at the moment. So
no, the only thing I would say is don't tell your patients that they're going to get a colon capsule, because they might not. But if we can broach that it is one of the new tests that's available, and it's possible that will be offered to you, but it'll be decided in secondary care.
Okay. How long do you think it will be before we'll roll it out widely, properly?
We're planning on the next couple of weeks. So UCL is already live. So any patients referred to UCL will be part of the pilot as to whether they can. We're going to go ahead in the next couple of weeks. But the reason why I'm slightly anxious about lots of people wanting capsule endoscopies is just our capacity to manage it. So the number of readers we have and the number that we can do per week.
Okay, and when do you expect to report the results?
Within a few days.
Oh, sorry, in terms of the study that you're doing at the moment, in terms of the early project, the pilot.
The pilot, probably in about a year, I think, is when they're going to end the study, and then they'll do the write-up after that.
Okay, that's really helpful. Thank you very much. Thank you. So let's just see, has anyone else got any other questions that they'd like to ask? Or Ed, have you got any other comments that you want to add? How has colon capsule been working at UCH?
It's thanks. It's very popular with patients for very understandable reasons. Nobody's heart fills with joy at the prospect of a metre-long camera up your bum. So colon capsule is brilliant for our low-risk patients. The other group, I should say, for these fit less than 10s, they obviously have a very low risk of colorectal cancer, probably in the order of 0.5%. And if we need to do luminal imaging on them, then colon capsule is perfect. Obviously, you don't want to do colon capsule on a high-risk patient because they're going to end up needing a colonoscopy anyway.
Yeah, right. Okay, that's really helpful. So you see, do you in the future, you're much more likely to be used in the younger population? Yeah.
Absolutely.
And at the moment, does the patient have to come in to get given it, or will it arrive in the post? So I thought they would soon be arriving in the post.
Yeah, so we've got this novel pathway where essentially your Amazon parcel arrives and you unpack your colon capsule, you do the procedure at home, and then a courier comes the following day and picks the recording device up. And of course, that's really good because particularly in COVID times, when people were shielding and things, or people were more anxious about coming up to hospital, it was perfect. So that we've only got a handful of patients who've gone down that pathway, so data is still weighted, but it looks a really novel, exciting, sort of patient-friendly process. So particularly if you have patients out there who are avoiding colonoscopy because of the concerns about either coming up to hospital or they're just worried about the actual act of a colonoscopy. Colon capsule is brilliant because I should say with a CT pneumocolon, you still end up having a smaller tube up your bottom. So this is
even better.
Bottom free.
Bottom free. Okay.
Yeah.
Okay, so on that note, what I'd like to ask everybody to do, I think because we've had different people have had so many different experiences in trying to access the different FIT forms, what we'll do is we'll have another check through all the different ways that that GPs can see these forms, and then we'll send something out to everyone who's attended in the first instance, which means we'll also have an opportunity to answer any extra questions. So I can see that Elizabeth Young has put a question in, which we'll get that answered in when we send out the information that confirms the best places that you can look, and there will probably be more than one for the different forms. If you've got any other questions at all, if you just want to post them, and you can just continue to post them, I think I'll say up until 13:45, and we'll collect all of those and answer those. Thank you very much. So I'd like to say thanks to Zarina for kicking us off and giving the GP view. Thanks to Sheena for telling us what's happening at the Whittington, and of course thanks to Ed, who's been instrumental in helping us with the FIT pathway over the last few years. Thanks to the team, and thank you to all of you for finding time to join us this afternoon. Thank you very much. Bye-bye.